Yeah, my name is Monir Mazaheri. I work as associate professor and senior lecturer at the Swedish Red Cross University College and also at Karolinska Institutet, which are located in Stockholm, Sweden. I feel very honored that I have the opportunity to present my study on different ethically challenging care situations here. Thank you, all of you that were here to listen. And also I would like to thank the organizer committee for inviting me here. Extra glad to be here in an event with Rangstad University, one of my most wonderful PhD students in Sweden who defended her thesis in 2016. They're also from Rangstad University. My primary research interest involves studying aging population, their relatives, and healthcare professionals in different situations, including but not limited to living with dementia, living with trouble conscience, and also older people in disasters. I'm interested in including culturally diverse population in my research studies and have a major interest in ethics. Here I present two of my latest studies. And then the focus in my today presentation is these three aspects: meaning of conscience, meaning of trouble conscience, and how the healthcare staff deal with trouble conscience in their caregiving practices. We have looked at different cultural groups to see what is the conscience and what is the trouble conscience for them. And we have conducted the studies that I'm presenting today with qualitative methods. And then you might wonder how did it started, why I have decided to look at the culturally different groups and how they are taking ethically difficult decisions. It started with a large quantitative study where the nursing staff in northern Sweden have been asked to answer 3 questionnaires about their perception of conscious, stress of conscience, and also burnout. Since one of the reasons for burnout is having trouble conscience, therefore it is important for us to detect and manage it to prevent the burnout, so people stay working, not living in the work because of burnout. The same study was repeated in Stockholm, and we were surprised by its results since nursing staff in Stockholm and in northern cities had very different perception of conscience and even the level of trouble conscience. People in Stockholm seems that do not mention that much trouble conscious, and that we were puzzled why. Since looking at the participants and setting, it was like the same care structure and conditions, working conditions. And the only difference was that the participant in northern cities had mainly Swedish backgrounds because there's less immigrants in north. Because it's smaller cities or villages and it's extremely cold in north, another factor perhaps also contributing. But people in Stockholm, that is very international city, have diverse backgrounds and were originally from different countries. Therefore, we decided to study the culturally diverse groups to illuminate the meaning of conscience, trouble conscience for them, and to be able to understand the differences that were shown in our previous studies. As introduction, I would like to explain how conscience plays a role in our professional everyday life, because it's why I'm focusing on the conscience. In ethically difficult care situations that we face in our everyday life as a healthcare professional, people react as a professional and also as a person. The professional response is influenced by shared ethical principles. For example, demand of doing good, not harming, respecting autonomy, and being just. And the personal response by factors such as family values, culture, and religious traditions being expressed as conscious. So they hear that conscious comes in the picture because that's influenced the personal response to ethically difficult care situations. However, these two responses, professional response and personal response, may come into conflict sometimes. Conscience is an important concept in ethics. The word conscience itself is used in everyday life and is attributed various meanings. Conscience has been described as, for example, clean, good, clear, and untroubled. In a multicultural society, people with different views on conscience have to cooperate, which demands understanding and respecting each other's view while facing challenges. An example is encounters of healthcare providers in non-Islamic environments with migrant people from Islamic countries. That was described as clash of cultures in an Australian study, for example. What is how conscience is understood in different cultural and religious background. In Abrahamic religions, conscience is regarded as emanating from moral principles that are divinely ordained or upheld and needing to be contextualized and informed, for example, by traditions. So it means that one cannot follow the conscience. It should be contextualized. There is no specific word for conscience in biblical texts in Hebrew. Looking at Western Christian traditions, that is rooted in Greek word synedis, related to civic responsibility and its effect, awareness of a bad conscience was regarded as a deliberating pain. In Christian traditions, conscience as having two parts of common sense and also particular actions. Looking at the secular Western traditions, conscience is often viewed as constructed, for example, by childbearing or the population's general will. In Islamic literature, different parallel words indicate the concept of conscious, such as al-damir, al-nafas, and qalb, with meaning self and heart. Perception of conscience has been found to play a crucial role in burnout of healthcare personnel. The perception of conscience as a burden and have to deaden one's conscience contributes to getting burnout, while a perception of conscience as an asset and an ability to deal with one's conscience is a constructive way, and perceiving support from those around them were among the characteristics of non-burnout staff. So it's really important to see these people that we are working with, which kind of understanding of a conscience they have. Is it as a support or is it as a burden? Because it has consequences on having them in the job market. Care of people with advanced dementia diseases and that are usually ended up in the residential care settings requires care providers take many ethical positions. And caregivers who feel they cannot provide care of high quality, for example, experience a state of subconscious that is a stress caused by trouble conscious. So that is the connection of the trouble conscious and stress of conscious. If it's repeatedly experienced, then it will be stress of conscious. The aim of a method in these two studies that I'm presenting here was to eliminate the meaning of conscience, meaning of trouble conscious, and how to deal We did among healthcare staff working in Swedish residential care setting. And we had both people with the Swedish background and also people with the immigrant backgrounds, including Persian-speaking people. We used the phenomenological hermeneutic design in this later part that we wanted to explore what these people understand. Perhaps they have different understanding of the conscious, therefore the result is different. Hermeneutical phenomenological hermeneutic design includes phases of naive reading, structural analysis, and comprehensive interpretations. That is according to the Lindes and Norberry's method. The meaning of conscious, troubled conscience, and dealing with it was interpreted in a dialogue, in a dialectic process between approaching the text as a whole and approaching its part between understanding and explanation. That is to say, between focusing on what the text says and what is opened in front of the text. The data was collected through audio recorded narrative interviews. The participants were asked to describe what is meant by the conscience. They were also asked to narrate situations from their care of older people with dementia diseases and from their childhood when they felt they had clear or unclear conscience, followed by probing questions. The interviews followed a guide, which was constructed by the research team. When we wanted to include people with the immigrant backgrounds, one of the first groups that we included, it was Persian-speaking care staff. Since in Stockholm is very diverse. The reason was that Persian-speaking group were among those that were overrepresenting in healthcare system in Sweden. On average, they have higher academic education than their counterpart Swedish or their or other ethnic groups. In Sweden, we have nursing people, nursing homes for people with dementia that are like different backgrounds, for example, for the Finnish-speaking people, Arabic-speaking people, and also other languages. So we started to look at, as the first group, to Persian-speaking people that are taking care of Persian-speaking people with dementia. As a description of the context of our study, I should say that we live now perhaps everywhere in the world, more or less, in more diverse societies than ever before. Sweden is not an exception. A feature of a healthcare system in Sweden, particularly in the care of older people that needs less expertise, includes including nursing homes, is its cultural diversity in terms of having considerable numbers of both caregivers and care recipients with an immigrant background. 12% of more than less than 12% of the population aged 65 or lower have foreign background in Sweden, and 19%, that is a quite big number, of enrolled nurses and nursing assistants in Sweden are foreign born. And if you look at the population of older people with dementia, that was the patient group that our participants were taking care of them, nearly 2% of them had dementia. Here comes the first part of results. The three constructed themes about meaning of conscience included perception of conscience, clear conscience grounded in relations, and striving to keep clear conscience. Conscience develops in childhood and is subject to growth during life. It is learned mainly from parents who also learn from previous generations. Therefore, is personal, considering different upbringing ways. Wider society, to a less extent, contributes in forming conscience. Conscience is also considered by the participants as a guidance system grounded in feeling to help people doing good things. Conscience engenders happiness or sadness in various situations based on what is done for others or the way of approaching people. To understand the value of what we are doing, conscience is a reference. If conscience is clear, then participant thought, okay, then we are doing fine. Because of conscience, we feel bad or good about what we do. And the participant expressed also having a clear conscience means to be in touch with one's heart and soul and what evokes a feeling of calmness and peacefulness. They also express that conscience is dynamic and changes over life courses. So it's not fixed from the beginning. Conscience develops gradually. It has a dynamic nature and changes during life based on our learning and our interaction with the society. Therefore, it varies among people also because we have different interaction with our surrounding environment. It is possible to suppress conscience, and then if one does something wrong against conscience, one would not get obsessed. Another part of the result was that they said clear conscience is grounded in relationship. For them, establishing good relations with others was meaningful to keep the conscience clear. Having a clear conscience means being able to form a bond with others, to respect them and get their confirmation that they are doing well. Having clear conscience means connecting to people with respect, and it was a mutual connectedness contributes to clear conscience. They believed that the participant believed that keeping conscience clear was a constant strive, which demanded being generous in helping others, doing daily tasks well, and behave nicely, since one day we would be treated the same way. Regarding the other part of the study, meaning of the trouble conscience, the staff with the Persian background were hesitant to talk about their own experiences of bearing trouble conscience. But they describe having a trouble conscience means not being a good human being, and also when they wanted to deal with the trouble conscience, it meant that they should compensate if they have done some harm, and also how to prevent. Trouble conscience, for them, it was hard to bear. Bearing a trouble conscience affected both their everyday life and also future, because what one does come back to him or her, according to the participant. Compensating for the possible harm to the others, which was grounded for getting a trouble conscience, or apologizing, could help to deal with the trouble conscience. Professionals who interact closely with people might experience having a trouble conscience more than others. In the coming slides, I compare the results of these two studies that I presented here with our previous studies. Means that nurses with Swedish background compare with the nurses with Iranian backgrounds, that all of them working in Sweden in Swedish residential care settings. Nurses with Swedish background, when they wanted to deal with the trouble conscience, they needed to talk about their bad conscience with their colleagues or with the others to be able to get help in their interpretation of the trouble conscience and what they did to deal with it. They also had a dialogue with themselves to find the right path. The conscience can give wrong signals, they believe. However, Persian-speaking nurses with Iranian backgrounds, they thought that no, they should follow conscience, and conscience never give wrong signals. They thought that is an inner guide, which they should be followed, and that a clear conscience is linked to relationship and in connecting to the people they care for. To maintain a clear conscience, nursing with Iranian backgrounds try to listen to their inner voice, and they felt that they need to mend their relationship with their care recipients by compensating for the possible ignorance or harm they felt responsible for by being a responsible caregiver. So as you see, the study showed some differences among these two groups with different religious and cultural backgrounds. The Swedish nurses needed to talk about their conscience, and they complained a lot. We continue to talk about the differences between these two groups. Persian-speaking participants presented stories at the beginning of interviews about their colleagues that had trouble conscience, because they did not want to say that, oh, themselves have experienced trouble conscience, because they perceived it is something negative, because it means that they have done something bad, that they are feeling trouble conscience. But slightly after, they started to talk about their own experiences, because they had a hard time talking about their own. Nurses with Swedish backgrounds, the studies shows that they had many narratives about the situation where they experienced having a trouble conscience, and they freely shared these with their researchers, as they were doing before also with their colleagues. They reported experiences of stress of conscience in their everyday practice. This contrast might be related to an understanding of the determinants of competent professional caregivers, as two previous studies on Iranian nurses in Iran have revealed that having a strong, clear conscience was considered to be a characteristic of clinical competency and commitment to their professional developments. Since the Persian-speaking nurses, they blamed themselves by relating the development of trouble conscience to being an uncaring person, not only as a professional, but as a person they perceive very negative, and not living up to their own values. They did not attempt to rationalize their own possible inabilities to meeting all the needs and desire of the residents. Is it the last slide to discuss the differences between these two cultural groups? The point of departure for the nurses with the Swedish background or nurses with immigrant backgrounds, here Persian-speaking people, and what the patients wanted. It was Persian-speaking people. They wanted to just satisfy the patients, regardless what. But the nursing with the Swedish backgrounds, they wanted to do, try to say, oh, what is good for them, even it doesn't make the patients satisfied. So they were, okay, what is good based on my professional knowledge? What is good for these people? Sweden-born nursing staff related their trouble conscious to factors outside their own beings, as a result of being catch between the conflicting demands of the residents, their relatives, co-workers, and those of their own life. They associated the stress of conscience to factors such as efficient social support from their supervisors and a low level of resilience. The Persian-speaking staff, they contrast might be related to understanding of the determinant of competent professional caregivers, and they understood themselves as being caring beings and not only caregivers. So they went behind the professional roles they attributed to the personal characteristics. Considering the correlation between having trouble conscience and the rate of burnout, according to the researcher, knowledge generated from this study and also similar studies should be used in tailoring caregivers' condition, particularly for those healthcare professionals who are most likely to develop a trouble conscience, in addition to empowering nursing staff to deal with trouble conscience and stress of conscience. Yeah, and here I come to the last slide. If there is any question, I will be very happy to answer. And here is also my email addresses, telephone number, and also this barcode. So you can, if you use this barcode, you can end up in my ORCID page that you can see my list of publication, also a bit biography about me and other contact details. Thank you so much for listening to me.
Thank you very much, Associate Professor Dr. Monir. All right. If there is any question, please feel free to ask.
Yes, please. I have one question. Excuse me, Dr. Monir, can you just suggest me a bit about the application of using conscience for us as healthcare professionals, for the patient or for ourselves?
Mm-hmm. Thank you so much for the question. Thank you, because the implication of this research or any research is important. So the thing is that in everyday life as a person, like in our private life or in the professional encounters with the patient or with our colleagues, we use our conscience in decision, okay, if it's good to do or not to do in everyday practice. And that is my perception of what is good to do and what is not good to do depends to my conscience, and conscience is colored by my religion or my cultural backgrounds or my interaction with the society. So therefore, it's very important to know these people that you are working with, your boss or your colleagues, what kind of perception of conscience they have. Because as a leader, if your staff have experience of trouble conscience and stress of conscience, it makes them to experience burnout and not be able to continue to work if the situation continues. So it's really important to be able to support them, how to manage their trouble conscience, but also more importantly, how they are making decisions. For example, if they are taking care of an older people with dementia that is not able to communicate, or a child or any other cognitively deteriorated patient, they cannot talk themselves. It's me as a caregiver, regardless if I'm a physician or nurse or whoever, who as a healthcare professional, how I choose to follow my professional task description or do other choices. So it's very important to see which kind of understanding, perception of conscience I have, which situation generates stress of conscience for me as a worker here, and how I manage my stress of conscience. I hope that is answer to your question.
Yeah, pretty much. Thank you very much.
Thank you.
I would like to say thanks again for the interesting presentations. Thank you very much, Associate Professor Dr. Monir Mazaheri.
Thank you so much.